Hi, welcome to another 10-minute topic. This is the second part of our hyponatremia series. We're going to look today at some case studies. So if you haven't checked out the first lecture, which is about an approach, then definitely worth having a look. Okay, so let's go straight into it. A quick recap from last time. So we talked about the triad of volume status for your patient, your OBS and your examination, JVP, mucous membranes and so on, the plasma osmolality, and urine sodium. We also mentioned excluding hyper and isotonic causes, so pseudo-hyponatremia, high protein states, high lipid states, and so on, and hyperglycemia. So we're going to use this as our reference diagram, and this will come up again a few times. For a bit of a recap, just pause the lecture and have a quick look now. So let's look at the case first of all. For a 57-year-old male presents to A&E with confusion and one witnessed tonic-clonic seizure. He's been there before for quite a few times with alcohol-related problems, and during his last admission, an ultrasound showed that he's cirrhotic and he's had an acidic drain before. So this time he started to wake up post-seizure, but he's still quite drowsy and he's not really giving you much history. It's not quite clear how much of that is due to post-seizure, alcohol, or whatever else. He is still drinking alcohol according to his partner, but is meant to be taking some medication for his massive belly. So here it is. So again, pause the slide and have a quick peek. So first of all, he's acidotic and has a high lactate. Why do you think that might be? I would suggest that he's post-seizure, so it's probably looking a lot better than it did when he had the seizure itself. Bilirubin's a little bit high. Again, that suggests a poor liver state. And that's sodium, 104. Oh dear. So this is acute. On examination, he's got that belly's come back, some good ascites there. He's got some peripheral edema, some classic spider nevi, a raised JVP, and some gynecomastia as well. So the sodium is very low. We think this is most likely to be acute, so acute severe. So time to step off the algorithm and think about emergency management, especially because he's very drowsy. So you've got a couple of options. Option one is probably the optimum, where you're going to want to get senior input. This is, we're on medical emergency territory here, to tell the med reg or the consultant. And I think an IT referral is most appropriate here. You're going to want level 3 care if at all possible. Ideally, you want to get the patient ready for a central line insertion. So think about what you need to do here, getting a clotting, group and save, space in theatre if needed, whatever you need to do. The aim with these patients in the emergency setting is to increase the sodium by 8 to 10 millimoles in the first 24 hours and no more than that. Afterwards, you can go up by about 8 millimoles per day. Ideally, you want to use hypertonic saline. That fixes this fairly quickly. So you can use 3% 3% sodium chloride as opposed to normal saline, which is 0.9%. You can use 150 mils over 10 to 20 minutes, recheck and repeat. And you're looking for a rise of 5 millimoles overall. This is based on the Royal College of Physicians guidance. Subsequently, the patient would then be switched to normal saline, and you can check the sodium 6, 12, 24 hours and do your investigations. We don't always have beds, and this patient may not be fit for ITU. They look like they've got severe liver failure. This is not your call to make, So you need to have the conversation. This is why senior input is so important. And if someone may need ITU, I would always have that conversation. So we're going to go down option 2, which is ward-based care. So there's no beds in ITU, so we've got to make the best with what we have. So consider the ramifications of this. So think about respect forms, conversations with family and their input, and so on. You want to get decent access, and you're going to use normal saline. I wouldn't use hypotonic saline on a ward. You can give it over a few hours and recheck. If he's waking up, starting to become less symptomatic, then you can slow down that rate. Your aim is still to rise 8 to 10 millimoles over the first 24 hours and no more. You want frequent neuro-wobs to see whether what you're doing is working, and again, that's senior input. So let's follow the algorithm. The ECF volume is increased, so we're going to go to the left side of the diagram. The urinary sodium is low, so again, right to the left. So urinary sodium less than 20, and you can see a bunch of causes: liver failure, cirrhosis, hepatorenal syndrome, CCF. He could have any of those. The other thing that alcoholic liver disease can cause is, well, let's have a look. Patients on ward-based care. The handover error led to the patient receiving a bit more saline a bit more quickly than he should have done, and his sodium's gone from 104 up to 121. He's still drowsy, but slowly waking up. But day 2, he's unable to form words, so he's got dysarthria, and he can't swallow properly, dysphagia. During your examination, he's got reduced power and reflexes in both legs. So this is osmotic demyelination syndrome, formerly called central pontine myelinolysis. It's changed name because it's been found that there are several patients that had extra pontine features of this. So this happens when you correct that sodium too quickly. So we're on day 2, we've done the MRI, and we think that he's got the first signs of myelinolysis. So what can you do now? So the changes can't really be reversed, but you're going to stop giving him sodium. If you've overshot very quickly, you can consider trying to reduce that overshoot. So this is based on what sources you read. Some units will use hypotonic saline to try and reverse that effect. So 0.45% or 0.18%. This kind of redilutes the plasma. There are case reports of people using desmopressin to achieve the same thing. I wouldn't be so keen on doing this because of its effects on blood pressure and the prothrombotic state in someone who's already going to be quite prothrombotic. But these are both possibilities. Okay, so let's move on to case 2. So we have a 71-year-old female admitted with acute shortness of breath and a productive cough and fever. She's got a past medical history of breast cancer taken out 10 years ago, hypertension, and iron deficiency anemia. So she's a vegetarian, let's say. So she takes amlodipine and ferrous fumarate. Chest X-ray shows a lump at the right base. She's got a mild anemia, as you would expect. Her white count is up, which is the neutrophilia. Platelets are fine. And her U's show that she's hyponatremic at 114. Potassium's fine. Urea and creatinine is okay. It's at her baseline. So let's have a look at what we think might be going on here. So she's got hyponatremia. Her ECF volume is normal. Plasma osmolality is 270, it's hypotonic. Urine sodium is 43. So looking down the diagram, we can see that we might be thinking about SIADH in this situation. Urine osmolality is 620. So that pairing with plasma osmolality, and you should be doing it at the same time, very suggestive. What about if you're not sure? Let's say this lady was a little bit dry when she came in, but that urine sodium is still high. If you're not sure, there is an easy test, which is to give her a slow bag of saline and see what happens. If the patient's dehydrated, then the sodium might go up a bit. If it says SIADH, then it will probably go down a bit. Wouldn't be doing this. So we think this is SIADH due to a potential malignancy or pneumonia. And in this lady, it turned out to be both. So the mainstay of treating SIADH is fluid restriction. So you can calculate the likelihood of how likely you are to succeed with this and how much to restrict with something called the first ratio. So you take the urinary sodium and potassium and divide it by the plasma sodium. Note that you need the urine potassium for this, so it is worth sending. So if the ratio that you work out is less than 0.5, you restrict them to 1 litre per 24 hours, 0.5 to 1, 500 mils per 24 hours. If the ratio is over 1, they're unlikely to respond to fluid restriction. So in some ways this really is worth doing because you can save yourself valuable inpatient bed days. So 2 days later, sodium's gone down to 112 and the creatinine's going up very predictably. Nurses are very clear, she is complying, they've got signs around the bed, everyone's keeping an eye, the family are aware, they're not sneaking her any Lucozade or wine under the table, and everyone is playing ball. So what are our options? So demeclocycline is option number 1. This is an antibiotic, the side effects of inducing nephrogenic diabetes insipidus to counteract the SIADH, and you give it 3 times a day. Other option is tolvaptan. This is an ADH receptor antagonist. It affects the V2 receptors, so this has a temporary effect of directly counteracting the effect of too much ADH. Last case. So we have a 45-year-old male presenting with abdominal pain and a pre-syncopal event, followed by syncope. This has all come on within the last 24 hours and is getting worse. He has a past medical history of antiphospholipid syndrome, and he takes warfarin. His INR is 2.6. His time in therapeutic range of that is 65%, so not great. He's got type 1 diabetes and has an insulin pump. On admission, he's pale and he's in shock. Blood pressure is 96/60 and his heart rate is 122. He's afebrile. No visible JVP, dry mouth with cracked lips, and he's passed a lot of urine. Sodium's low at 113, his potassium is quite high. His renal function is not great, but his glucose is relatively normal. And one thing I haven't put on the slide, but his ketones were also normal. This is not DKA. His plasma osmolality is low, so he's hypotonic. His urinary sodium is a little bit high at 31. Thyroid function is normal. His capillary blood glucose is normal, so this isn't hypoglycemic cause, and this is further supported by the fact that the osmolality shows he's not hypertonic, as you would expect in hypoglycemic hyponatremia. His INR is 1.2. So let's have a look at the algorithm. So his ECF volume is decreased, his urinary sodium is over 20, so we're going to go to the right-hand list, and this looks like renal causes. So diuresis or salt and water loss through the kidneys. So what's the diagnosis? Let's put the pieces together. So he's hypotonic, hypovolemic hyponatremia with a high urinary sodium. He's also hyperkalemic. He's got abdominal pain and shock, a low cortisol, an autoimmune history, and a subtherapeutic INR with APLS. This is something to do with his. No mysteries here since the arrows are already included. So this is pointing to the adrenal glands, and this shows areas of hemorrhage. This is bilateral adrenal hemorrhage secondary to infarction. So adrenal insufficiency. His poor therapeutic range with warfarin has allowed his antiphospholipid syndrome to start causing clots, and he's clotted off his adrenals. You need to treat the underlying cause. So first of all, I'd want to get a surgical opinion, a hematology opinion, and an endocrine opinion. And most likely you're going to use replacements with hydrocortisone or fludrocortisone support, and Snackton tests on their advice. However, all this is meaningless if your patient. And that's all. So, difficult topic, not the most straightforward cases. This is worth reading up on as it's very common and it can get quite complicated. I found the RCP guidelines and learning materials pretty useful, so definitely worth checking those out. Quite a bit longer than 10 minutes, but hopefully time well spent. Cheers.